Hi, this is Amber Knowlton. This is Nursing 2212. This is Chapter 38 on venous thrombosis or VTE. Venous thrombosis formation is the formation of a thrombus with inflammation of a vein. It's the most common disorder of veins. It's classified as either superficial, where there's a clot in a superficial vein, or a DVT, there's a deep clot in a deep vein, for example, the iliac or femoral veins. VTE, venous thromboembolism, is the preferred term and represents a spectrum of pathology, anywhere from a DVT all the way to a PE. Virchow's triad, this is the etiology of a venous thrombosis or a VTE. So the patient will have venous stasis. This usually occurs in obese, pregnant patients, patients with heart failure, atrial fib, patients that are traveling, post-op patients, or patients that are immobile for a while. Damage of the endothelium, inner lining of the veins from like trauma, burns, damage to a vein, chemo, sepsis, and hypercoagulability of the blood. So conditions such as anemia, polycythemia, malignancy, sepsis, oral contraceptive use, and tobacco use. VTEs, the pathophys, it's a localized platelet aggregation and fibrin entrap RBCs, WBCs, and platelets to form the thrombus. A frequent site of thrombus formation would be at the valve cusps of veins. Thrombus enlarges, it is increased in the number of blood cells and fibrin. The thrombus continues to form into a large clot with a tail that blocks the vein, and the thrombus can detach and result in an embolus. In your book, figure 38.9 is a map of the pathophysiology of a VTE. So clinical manifestations, patients may or may not have leg edema, pain, tenderness, dilated veins, sense of fullness in the calf or thigh, paresthesias, warm skin, erythema, a temp greater than 100.4. So remember, these are venous conditions, not arterial, so the patient will have a peripheral pulse. Complications of a VTE, the priority that we're trying to prevent is a PE, pulmonary embolism, and we discussed these in Unit 1. Another complication of a VTE would be a post-thrombotic syndrome, chronic venous hypertension caused by valvular destruction from inflammation and scarring, stiff non-compliant vein walls, and persistent venous obstruction. So symptoms of post-thrombotic syndrome would be pain, aching, heaviness, swelling, cramps, itching, tingling, edema, eczema. They might have a venous ulceration. This typically begins 2 years after having a VTE. And another complication, phlegmasia cerulean dolens, which is a swollen, blue, painful leg. This is rare, but it may be seen in advanced stages of cancer. So different diagnostic studies are used to help diagnose VTEs. In your book, Table 38.9 lists all the diagnostics used. Sometimes a D-dimer may suggest that there's a VTE. CAT scan would be a priority to diagnose a pulmonary embolism. And ultrasound also localizes clots as well, especially in the extremities. So prevention is key with VTEs. We want to have the patient change positions every 2 hours, flex and extend their knees, their hips, their feet every 2 to 4 hours, out of bed, up in their chair for meals, ambulating 4 to 6 times a day, the use of elastic compression stockings, TED hose, SCDs, medications, anticoagulants. These are prophylactic to prevent blood clots, and anticoagulants do not dissolve a current clot. They also don't stabilize a current clot. They just prevent the formation of clots. Vitamin K antagonists, Warfarin, also known as Coumadin, takes 48 to 72 hours to be effective. So we want to make sure we're overlapping our warfarin with a low molecular weight heparin, such as enoxaparin. With warfarin, we want to monitor a daily INR. The antidote for warfarin is vitamin K, and we want to make sure the patient's not taking NSAIDs. Patients on warfarin need diet changes, diet teaching. Green leafy vegetables, for example, are high in vitamin K. So we don't want the patient to necessarily change their diet. We want their diet to be consistent. So whatever, if they eat foods that have a lot of vitamin K, we want them to be consistent with the amount they're eating every day so that they're not having the peaks and the lows of vitamin K, because that'll affect their Coumadin level, their warfarin level, their INR. Any patient that's on a heparin, a low molecular weight heparin, warfarin, we want to be conscious of precautions for bleeding, no intramuscular injections. With heparin, we want to make sure we're monitoring their PTT. Thrombin inhibitors such as heparin sub-Q can be given prophylactically. Can also be given IV for VTE treatment. If the patient actually has a clot, we can treat it with heparin and monitoring their PTT. Surgical therapy is another option for patients with VTE. So these patients need coagulation monitoring, dose adjustment, not necessarily, or excuse me, surgical therapy, let me back up, is another option for patients with VTE. So open venous thrombectomy to remove thrombus through incision in the vein. There's a vena cava interruption. It's inserted percutaneously through the femoral artery or the jugular vein, and a filter device opens and pokes, open spokes penetrate vessel walls, and the filter catches clots. It does not interrupt blood flow. And there's a picture of this in your book on page 852, figure 3811. Nursing management, all the subjective and objective data for a VTE is in your book on page 853, table 3812. So some nursing diagnosis: acute pain. Warm packs can help with this pain because warm packs, the warmth dilates the vessel. Ineffective health maintenance, risks for impaired skin integrity, potential complications such as bleeding or a pulmonary embolism. So our focus is on prevention of emboli and reduction of inflammation. We want to review medications with the patient that might interfere with anticoagulation therapy, monitoring their INR, their PTT if they're on heparin, INRs with warfarin, monitoring their CBC, their platelets, depending on what medications we're using. We want to teach the patient to report any signs and symptoms of bleeding, black bloody stools, bloody urine, coffee ground emesis, nosebleeds, assess for hypotension, hematuria, melena, hematoemesis, petechiae, ecchymosis. In your book on page 854, table 3813, lists the nursing interventions for patients taking anticoagulants. And we also want to encourage our patients to have early ambulation. Home care for VTE, we want to modify any of those risk factors, the use of compression stockings, the importance of monitoring labs that we talked about, medication instructions, the importance of follow-up care, teaching the patients and helping them with interventions to stop smoking, avoid constrictive clothing, stopping oral contraceptives, changing positions frequently, no prolonged standing, no prolonged sitting, teaching the patient signs and symptoms of a PE and when to report those. Active young patients should avoid contact sports if they're on anticoagulants. And the older patient, we need to emphasize safety at home to prevent falls if they're on anticoagulants. Patients should be on a well-balanced diet. We should teach them about a diet with warfarin and to avoid those vitamin K foods and to avoid alcohol, or to keep whatever their intake is the same every day so that there's not the highs and the lows with their INR. And overweight patients need reduced calorie intake and to increase their physical activity. So our evaluation, we want the patient to have minimal to no pain, intact skin, no signs of a hemorrhage or occult bleeding, no signs of respiratory distress. Remember, our priority is we do not want the patient to develop a PE. So moving on to Buerger's disease. Buerger's disease is a non-atherosclerotic, segmental, recurrent inflammatory disorder of the small and medium-sized arteries and veins of upper and lower extremities. It's a rare systemic. Manifestations may include cerebral, coronary, mesenteric, pulmonary, and/or renal arteries. Occurs mostly in young men, especially with a history of tobacco and/or marijuana use, and chronic periodontal infection, but without any other cardiovascular risk. In the acute phase, an inflammatory thrombus blocks the vessel. The thrombus becomes more organized and inflammation subsides. In the chronic phase, thrombosis and fibrosis occur in the vessel, causing tissue ischemia. The symptoms are similar to peripheral artery disease. Claudication of feet, hands, arms, resting pain and ulcerations develop, color changes, temperature changes of the limbs, paresthesia, superficial vein thrombosis, and cold sensitivity. No labs or diagnostics are used to diagnose Buerger's disease. It's diagnosed based on age, symptoms, involvement of distal vessels, presence of ischemic ulcerations. We want to exclude any autoimmune disease, diabetes mellitus, thrombophilia. The treatment is cessation of tobacco, whether it be they're smoking tobacco or smoking marijuana. Avoid limb exposure to cold, exercise, antibiotics for ulcers, and analgesics for pain. Surgery is an option. Sympathectomy, which is a transection of nerve, ganglion, or plexus of sympathetic nervous system, or implantation of spinal cord stimulator, or bypass surgery is another option. In severe cases, amputation may be required. Raynauds phenomenon. This is an episodic vasospastic disorder of small cutaneous arteries. It involves the fingers and the toes, primarily in young women. It may be an isolated event or occur with an underlying disease such as RA, rheumatoid arthritis, autoimmune diseases such as RA, rheumatoid arthritis, scleroderma, lupus. Can be occupational related, working in cold conditions, exposure to heavy metal, lead. The diagnosis is made on symptoms for at least 2 years. Characteristics would be vasospasm, induced color changes of fingers, toes, ears, nose. Patients will have a pallor, white color from decreased perfusion, cyanosis, rubor, a red hyperemic response when the blood flow is restored. Then they'll have throbbing, aching pain, tingling, swelling in the hyperemic phase. This usually only lasts minutes. Exposure to cold, emotional upset, tobacco, caffeine can bring on the symptoms. Thickened skin, brittle nails can also occur after prolonged attacks. So we want to teach the patients how to manage their Raynauds phenomenon, wearing loose, warm clothing, avoiding those temperature extremes, stop all tobacco and avoid caffeine, stop drugs with a vasoconstrictive effect, such as cocaine, stress management, and calcium channel blockers are the first line drug therapy.